Kokroko, 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 Mirinjoy, Uti Warada, Namye, Uye Kokroko. Oh, Amonsan, Mumramese, oh, Hawaii, Free Mundo, Amanze, Free Mundo, Ninyamye, Osamere, Kami, Amami, Mirinjoy, Uti Warada, Namye, Uye Kokroko.
Good morning. Good morning. Sorry, it looks like we have a low battery here. If they can change this for me. Good morning. You're welcome to day 2 of the 2022 Health Summit. I want to call on Mr. Shehu Bene, a manager at GAKI, to give us the opening prayer. Mr. Bene.
Good morning, ladies and gentlemen. Could you stand up for some prayers? Yesterday we had a successful meeting. We thank Almighty God, the most compassionate, the most merciful, to continue to shower His blessings on Ghana. We commit the President of the Republic of Ghana, Nana Dankwa Akufo-Addo, the Minister of Health, the development partners, and all the stakeholders for God's blessings and guidance to continue to shower on us so that at the end of it all, we give thanks to Allah. Amen.
Thank you very much. On behalf of the Honorable Minister of Health, the Chief Director, and our special guest, Dr. Anefi Asamoah, I welcome you to the second day of this summit. We had a successful day yesterday, and taking a leaf out of the book of Prof. Adanu, he says if it's good, we should just leave it as good and leave the ifs and the buts for later. So yesterday we said the report was good. Our performance for the year 2021 was good. Can we give ourselves a round of applause? To give you a brief of our statistics of how well we are doing in terms of patronage for the summit. On our summit site, we've had about 1,044 users as I stand at the moment. And we have users coming in from the Americas, from Africa, from Asia, from Europe. The highest numbers we are getting is from Africa. We have about 979 from Africa. We have 36 from the Americas. We have 19 from Europe, and we have 11 from Asia. 79% of our users are returning users. It means they didn't just hit the site once and they never came back. So we've had users who have returned to the website because they have found it useful. So we're doing well, and we hope to continue today with our program today. So as we mentioned yesterday, today is the focus of the theme for the summit. So we would have some presentations that center on the key issues we want to focus on so far as health information systems are concerned today. And we'll be going into our panel sessions in the course of the day after we've had our presentations. I want to acknowledge Dr. Aziz, the president of GAKI. Yesterday, he was the first to be here, and today, too, he was the first to be here. So he's in a very comfortable lead. So thank you very much, Dr. Aziz. We take inspiration from you for the rest of us to be here on time so that we can, especially tomorrow, we come on time and then we can leave on time. Today our lead MC is Dr. Linda Vanotu. So I'll hand you over to Dr. Linda Vanotu, and then she would take us for the rest of the program. Thank you.
Thank you very much, Sammy. Good morning, everyone. We thank God for another day, as we have heard through the prayer. And Kwame has told us that today is actually when we're going to delve deeper into health information. But for those of us who were in the meeting yesterday, I took a lot of things from the discussions, and I'm sure you did too. When you have Dr. Samwaba reading, it reminded me of many years ago when he was helping us to find our feet within the health sector. Dr. Samwaba, good to have heard you yesterday. And from what we heard yesterday, from Professor Danu and everybody else who discussed the topic that we had yesterday, I realized that there's a lot that needs to be unpacked. And that also reminded me that we have to go back to the basics. That's why. Why is it that we have the figures as we saw in the presentation? What is it that is pushing the figure forward from behind and beneath? And those are the things that we need to understand. I hope that you also took your part and will be working with them. It also shows that there's a need for a lot of collaboration, working with different people to be able to make health what it should be for us all to have the UHC that we are looking forward to. So today we're going to continue, and I welcome everyone. There are so many people online. Yesterday we had over 200 online. Today gradually we are getting there. So I want to welcome all of you. We'll be mentioning some names as we go along. But for now, suffice for me to introduce the next item on the agenda, and that is reflections on the e-health system, the LIFE. So we will go straight into that and have that presented to us. Thank you.
Thank you very much. Can we have the screen come down, please?
Electronic health fits well into the government's digitization agenda. Since the SDG came into being, universal health coverage has become one of the targets we need to surmount as a country. And one strategy the Ministry of Health is trying to employ is to be able to reach everybody on a digital platform and to connect every health center with a digital solution. Lightwave Health Information Management System is an innovative ICT solution that has been adopted, tested, piloted in Central Region, and the Ministry of Health has found it to be very user-friendly to roll out nationwide to be able to bridge the gap in our digital drive. One of the distinct features in their implementation strategies is the application of joint application development, where they bring their solutions to you, you adapt it to suit your institution. This particular solution is distinct, said that it has its own backup systems and then repository outside the facility, and then facility can also do its own backup. The other thing about LIMS that makes it very distinct is that it's live and it uses only Wi-Fi, and this is only a very small part of when you need to transmit data, especially to the NHIs. Other than that, it uses a local area network, the LAN. Apart from that, it makes application secured. If anybody takes any of the tablets outside the hospital, it will not be able to open and view patients. So it secures our confidentiality and then the security that we have been talking about. The hospitals and then the administration in general is benefiting a lot from this innovative solution. OPD attendance, for instance, I can cite Kolebu Polyclinic, which used to hover around 280. As soon as we went live, they went between 600 and 800. And the simple reason that everybody has to be recorded before the system allows you to see the patient. Our wake load analysis was proper now. We could see how much we are actually working output-wise. Our finances got better because we are getting most of this. And then utilization of our resources, which is the stores and supplies, we could know how many people are utilizing us. The fear of change is one of the biggest challenges that we had in the institution. The fact that people were afraid moving from pen and paper and we needed to do a lot of support with them. And then as I said, the JAT session and UAT sessions, that training sessions, calmed a lot of fears of our staff. There were challenges inherent in the hospital before the software came. That has to do with if you don't have a generator already. Human resource was also a challenge because you didn't have, for instance, in Cape Coast, for instance, we had only one ICT person. But by the time we finished and we got financial clearance, as of now, I think they have more than enough. My recommendation is that for standardization and for Ministry of Health to be able to roll out faster, I think we need to adopt Lightwave Health Information System as a standard electronic solution for our digital health rollout. Because when we get standalone, several of the standalone interface becomes another major challenge. We should also be able to talk to the banks, especially areas where we have two banks. Sometimes talking to the two of them to interface becomes a problem. So we should be able to get on-site banks that are willing to interface. If they are not, then they should allow the facility to get banks that are ready to work with them. That's my recommendation, and we should support the government digitization system. Because it saves lives and will make Ghana safe.
The LIMS, or the National E-Health Project, is one that has come at a good time, and it's helping us to address some of the challenges within the healthcare space. Now, one of them is, first of all, helping to improve data collection. Now, you can see that for facilities as big as Kolebu, we have over 1,500 outpatient attendance every day. And so all these patients, their records, keeping track of all these records, and even finding enough space to even store these records is a challenge. So having an electronic system immediately improves access to the records, also the ease at which patients are processed through the system. The other key thing that we're having also revenue leakages, where because people have not been entered the system, they can pass the back door and do all sorts of things. But now that we have an electronic system in place, it's much more difficult to do that. Also good for helping us to keep track of our data, because this is also a research institution. One of the key things that we do is research, and so if we're able to keep track of the data of why are people coming to hospital, what are the conditions that are affecting them, we can go, what are the age groups, what are the different characteristics, and then once you can have that data and it's accurate, it helps you to be able to engage in proper research that will help us to be able to come up with solutions to some of the health problems that confront our populations. Some of the models or the functionalities in the system, one of it is like having an appointment or calendar system, so that it helps us to be able to keep track of how many patients are being booked at our outpatient clinics. Because previously you come and the clinics are very overcrowded, but it helps to book patients and you're able to keep track of how many patients you book on a particular day, what sort of time they've been given and all that. We're able to request lab investigation through the system. We're also able to write prescriptions within the system. Doctors can now access the results via the electronic system, which makes it more convenient so that nobody has to go and chase the results at the lab. Then the other functionalities are also for management to see what is happening on the ground, how many people attended, what's the revenue situation, how much has come in, and those things. So the information that informs management, it's also one of the functions. Then we can also look at NHI claims, because these claims for NHI can be processed electronically using the LIMS systems. Inpatient management, our ward state, our bed state, all those are things that help can be monitored with the LIMS system. And also billing of patients. It facilitates accurate billing of patients. If there's any mistake, you can go to the system and see what is. And then also, you can also plan your workforce, duty rosters, planning various shifts, making sure that you have the right competencies of personnel. So all these modules or functionalities within the system are quite very good and help to improve the efficiency and effectiveness of the healthcare delivery. One of the things that we've seen are improved processing time, improved revenue. It's also made it easier to manage our records, and also we don't have to now look for space to store all these bulky files, because it had become an issue where sometimes we had run out of space to even store the physical folders. We had some initial challenges which we are resolving. Unfortunately, we were not lucky enough to have a huge investment in the infrastructure. We're giving some computers initially, about 250 by the ministry, and the hospital has tried over the last 2-3 years to procure more computers. We also have to make sure that access levels are clearly defined, and those are internal policy issues that will have to regulate who gets access to what kind of information, who has the privilege to do what within the system. So all those are some of the challenges that we confront initially, but with training and then with further investment, we are resolving some of these issues. And then of course the other thing is human resource. The IT has now become a very, very essential part of the hospital's running. And so 24/7, we have to have IT team around the clock 24/7 so that they can troubleshoot and they can, deal with problems as and when they arise. One of the areas that we want to see improvement is about the logistic management, because there's a GeoMIS software which is very good with logistics management within the healthcare space, and we think that if the LIMS can, the two softwares can talk to each other to help us be able to monitor, our consumables, our supplies, so that we don't run out of stock, unnecessary, so that we can be able to predict when we need to order, things, and we'll also be able to track items or supplies that come in right down to the end user. We would like to thank government and then the Minister of Health for this initiative. It was timely, or I would say it was overdue. We are grateful for that we are seeing this day, and then I believe that all of us should give it our full support so that we can get the best out of it.
We will come back after the lights out. Dr. Banotu.
Yes. Can you hear me?
Yes, we can hear you loud and clear, please.
So that was very good. And let me take this opportunity to also welcome all the staff and management who have joined us from the hospital. In fact, this time round, we have a lot of staff who have joined from the hospital and also from the health training institutions. Previously, when we were having in-person summits, it wasn't so easy for people within the hospital to join in the numbers that we have done. So we are very, very grateful to you. You are all most welcome. Ladies and gentlemen, we are moving on with the agenda. And the next is a presentation on global perspective on health information systems. From what we just heard, we realize that it's important to know what is happening at a global level. And I'd like to invite Dr. Benson Joti, the technical lead for HIS WHO Africa, to do the presentation.
Good morning. I hope you can hear me. Linda, if you can just help confirm that you're able to hear me.
Yes, Dr. Joti, we can hear you loud and clear. We'll be grateful if you can do the slideshow for your presentation so that it will be legible for us. Thank you.
Thank you so much. And first of all, I feel honored to be invited to talk to you about the global. I know that you said it should be global perspectives on health information system, but what we decided to focus on is the regional perspective on the health information system, particularly focusing on the African region. And as I said, I feel honored to speak to you about our regional perspective. I'll just a moment. Okay, so I'll just give you a very brief introduction. And then I talk about the status of health information system in the African region. The African region I refer to is the 47 member states of the WHO African region. Then I'll give you some highlights of the key reasons for the underperformance of the information system and what changes should be expected or countries should undertake to strengthen their information system. Also, I will talk about some of the key sources of data that countries should focus on and prioritize. and I will end the presentation by talking about harmonization and integration of health information systems. Just a very brief background. Strong health information systems, as you all know, and also listening to the presentation from Colorado Hospital, is that strong health information system is central to achieving better health outcomes. And of course, as you all know, strong health information system, we consider it as the backbone of strong health systems. So accurate and timely information is often required for countries to develop policies, plans, and of course also to track their progress. Having good quality and timely data requires the member states to have robust health information systems. But what is health information system? The definition we provided the data is that health information system is that system for the generation, storage, transmission, analysis, and use of health data to support decision making. The goal of a national health information system, from our perspective, is to ensure that there is always availability of good quality and comparable data that countries can use. And of course, a good health information system should be robust and should bring together all the relevant partners and ensure that users of information have easy access to data. And this point is particularly important, the last point is particularly important because, as we know, in many countries in the African region, there are policies that restrict access to data. And therefore, when we are saying data, to improve data use, access to data must also improve. So we look at health information system along 4 pillars. We have governance of health information system as one key pillar, perhaps even the central one. And we also have systems for data generation, storage, and transmission. Then we have systems and capacity for data analysis and synthesis. And also we have the whole work around communication and use of data. Data use is one of the critical components or pillars because where data are used, efforts are always put to improve their availability and quality. And all these 4 pillars, we consider them inextricably linked, and they should be the key area of focus for any country. So some statistics. This is based on the SCORE assessment. I'm happy to report one of the key people that participated or that led this analysis of data on the SCORE on the state of health information system is from Ghana. That is Anthony, also was a key part of this. So what I'm going to present to you is what is for the region. Ghana also has a specific report on their SCORE assessment. I think the Minister of Health should be able to do that presentation. But what we see from this graph is that in the African region, in the 47 countries, capacity for national health information system is still insufficient to generate good quality, disaggregated, and comparable data in a timely manner and use it to support decision making. This is a very big gap. It's what we see across most of our countries in that region. Routine health information systems are often beset with data quality problems, completeness rates are low, and the data tend to have high inconsistencies. But of course, countries that are implementing DHIS2 in Ghana, you'll find these are games. I think we are seeing increasingly better availability, better completeness, and better consistency of the data. Now, the key gap that we have also in the region is related to the work around the civil registration and vital statistics systems. If you see on the graph, the C on the graph, I hope you're able to see, the C on the graph stands for the count of births and the deaths. What you see on this graph is that 30 countries in the African region have almost nothing going on around the reporting of births, deaths, and causes of deaths. part of the seven country. That's close to 2/3, which is quite something that we should try to focus and improve on. Only one other country in the region was classified as having sustainable capacity for civil registration and vital statistics. I'm sure when you look at the score results for Ghana, you'll be able to situate where Ghana is in relation to these score assessments. Also, facility assessments are infrequently done, and I believe that also should be the case for Ghana. I think we had a conversation recently with colleagues in Ghana about the need to conduct facility assessments such as the harmonized facility assessments. This is just a breakdown of the score results by the key elements. We have S is really something related to the surveys. I'm not going to go through everything that is here, but what is just critical here is to see those in the red or the pink bars that you see, which show there's nonsense capacity. Nonsense really means there's nothing going on, and most of our countries have either nonsense capacity or between nonsense and moderate capacity, which is something which is actually worrying for the region. About a month or two ago, we participated in the work committee, the work of a high-level ministerial meeting in Accra, and actually the piece of data availability and quality actually came up for monitoring the UHC, and I think the member states at the time agreed that actually there should be a greater focus on improving the information systems so that data for monitoring progress and performance are available at all times. This is just to show you that, yes, there's gap in data availability, but it does affect all indicators. Data are available for some indicators, and also for some of them, actually data are not available. Particularly the NCD data in that region is, I think, NCD is one area where we are struggling with data availability and quality. But for reproductive, maternal, neonatal health, data are mostly available. Now, some of the key reasons why we are having these gaps in that region. One is the insufficient appreciation of the importance of data in decision making. We know that not all decisions are based on data. There are some decisions that are based purely for political reasons, but data still should come in and play its role in informing how political decisions can be implemented appropriately. So, across the region, we know that there is insufficient appreciation of the importance of that. Secondly, there's a lack of good quality and up-to-date HIS strategic plans, policies, legal frameworks, and also many countries lack data architecture framework, and where these are available quite often, they are not adequately elaborated. Critical fragmentation of the health information system, which in many countries tends to be driven by partners, and of course poor coordination of the partners and the investments around the priorities for national health information system. So many partners set up systems, the government sometimes is not aware. So that, of course, reduces access to data. You will forgive me, I'm in a place where there's a bit of background noise. Data systems such as the single places of vital statistics, I don't know the situation in Ghana, but the situation in many African countries is that the Ministry of Health is largely playing a peripheral role. Yes, we know by law in many countries, the mandate to register births and deaths is the responsibility. The mandate lies with the Ministry of Home Affairs or Ministry of Interior based on which country, but the responsibility to report is actually ideally aligned with the Ministry of Health. So the Ministry of Health currently in many countries is not playing that leadership or central role. Is a reporting of births and deaths, both at facility level and community level. That's why you see the graph that I showed earlier. Up to 30 countries have nothing going on. That's not really mean that data on births are not available. Facilities are always collecting data on system rated. Then that one is of course limited investments in information system, in the adequate number and limited capacity of health information system workforce. Each time we go to countries, we know the health workforce, the offices are one of the most dilapidated in many countries. The staff are at the bottom of the pyramid or the gamma. They're the ones that receive the lowest pay and so on. Then of course the use of paper-based systems. I really like the presentation that came from the hospital, the digitization of information systems, and that is the way to go. Paper-based systems are cumbersome. They increase the burden of reporting on health workers. They are largely inaccurate, they produce a lot of errors. So that is also affecting our information system. And finally, the limited use of data, which I already talked about. As I said earlier, where data are often used, efforts will always be put to improve their availability of quality. So what changes do we expect countries to have? What should happen in the countries? One is countries should have a stronger system for governance for health information system. By that, the number of components here, clear articulation of and more up-to-date strategic plans, policies, and legal documents. Clear articulation of the national data structure framework with the prioritization of all the key data sources. A more harmonized and parsimonious set of indicators defined along the life course. A more integrated national health information system. Enhanced partnerships, shared priorities, aligned resources, great curriculum for countries to have. And also more federal data sharing policies, which will actually enhance data access. Quite often we say we should not differentiate between data sharing and data security. Quite often we go to countries, what we see is that countries are emphasizing data security, which is correct, but they're using that to restrict access to data. Data should be used, and if actually countries put in place favorable policies for sharing data, then we'll be having improved availability of data for use. A more enhanced health workforce is needed in all the countries, and also the role of academic institutions should really be considered in many countries. And of course, better alignment with international goals and standards for enhanced quality and comparability. Here we're looking at standards such as the WHO Fund of International Classifications. Ghana, I think, recently started transition from ICD 10 to ICD 11, which is really great. And Ghana, I think, is one of the few countries in the region that has made that transition so far. The second one is around having strong systems and capacity for data generation, storage, and transmission. And that should take advantage of innovations in information technology. So the digitization information systems, having highly optimized data is to having use of electronic medical record systems to enhance the speed, accuracy, and efficiency of data collection, improve the quality of routine data through regular assessments of quality and data quality and so on. And of course, importantly, robust synchronization and vital statistics systems in the country. Increased frequency of household and facility assessment surveys actually should we really need these surveys. Facility assessment surveys, household surveys. I think Ghana did the demographic surveys coming up. I think in Ghana, one survey plus is coming up. The already conversations around implementing the harmonized facility assessment, which will provide a unique amount of data that Ghana will benefit from. Then improve the availability and the quality of identity data on human resources, logistics, we have this for the hospital, infrastructure, and finance. Importantly, of course, improve the implementation of the data standards such as the Digital Fund of National Classification. ICD 11 will have the International Classification of Health Interventions, which is critically important for insurance, international classification for function and disability. Yeah. Then the other pillar where we expect to see a big change is stronger systems and capacity for analysis of data, including data quality analysis of ICT coded data, inequality monitoring, using big data and advanced predictive analysis to improve performance and deliver impact. And lastly, of course, there should be enhanced data and information access. So I want to go through everything that is here in the interest of time. Now, this is slide shows some of the key sources of data that countries should consider. At facility level, of course, routine health information system, we are aware about this. Facility assessments, I think this I might be wrong on this. I believe this where Ghana is particularly hasn't done much work on around harmonizing facility assessments and so on. And of course, the GI-based master facility list. For the administrative records, I talked about the civil vital statistics systems, research, household surveys, surveillance, model estimates. But what is particular about these estimates that each of these data sources is unique and addresses specific data needs. So it is important for countries to prioritize all of them. Second point to note about this is that all the systems should be within a single framework of national health information system and ideally under the leadership of the Ministry of Health. Even if partners are set in separate systems, they should be within the national framework of the health information system. For civil registration of vital statistics, registration of birth and death is, as I mentioned earlier, is the responsibility of the civil registration office. But the collection and the reporting of data on the birth, deaths and the causes of death is the responsibility of the Ministry of Health. Finally, under this is that the primary focus is very important. The primary focus should be on strengthening health information at district level. That should really be the focus. Data generation, data use, the focus should be at facility level and the district level. And the district level. Automatically, if you strengthen that, data will always flow to the national level. So this is my final slide. It's just how you can integrate all these systems using one harmonized approach. This is really about the importance of having a one harmonized approach for information systems. You can do that. You have DIMS in Ghana, it's called the DHS in other countries. All the systems that you use can actually go through DHIS2, at least having a central repository. It can be the DHIS2, it can be a national health observatory. And what is important is that all the systems are speaking to each other. I think Dr. Opoku made this comment also as I listened to him, that systems will be able to speak to each other. Either you integrate them or they should be able to speak to each other. So if you have this, then at least you'll be able to improve one, the availability, two, the quality, and three, the use of the data for decision making. So I thank you. I will stop here. Thank you.
Thank you very much, Dr. Oti. That was very comprehensive and lots of food for thought. And I believe that sets the stage for our next presentation. Ladies and gentlemen, kindly take some notes. And if you have any question or comment, you can put them in the chat. We'll be very happy to hear your feedback. So we're going to move straight on with our agenda. And the next is a presentation on the draft health information system strategy for Ghana. And this will be presented by Dr. Eric Nsia-Boateng, Head MMU of the Ministry of Health. Thank you. Doc, you are welcome. Please take the stage now.
Okay, so thank you very much, Dr. Van Otu. And good morning to everyone. So this is the time of Ghana to also share with the stakeholders and participants what we have put together to strengthen our health information system. So we will share with you the Organization of Health Services in Ghana, the health services data that we have in this country, and also look at the analysis, the situational analysis of our health information system. We also look at the objectives and strategies that we have put together in this particular document that we expect to implement going forward. And also look at the management and coordination arrangements that we believe can help us to implement this particular strategy. The monitoring evaluation arrangement that we have also put together, we will share with you. And finally, the implementation arrangement of this particular strategy. So as we all know, the goal of the health sector is to increase access to quality health services for the population that we are serving. And before we can do that, we all agree that we need timely access to quality data or health information system. And I'm happy to say that there's strong recognition that from all stakeholders that we need to set up this system so that we can do the analysis that will inform our decisions going forward. So we, as a ministry, we plan to set up and integrate health information systems across all levels of care. But unfortunately, the investment to do that, as we all know, is limited. We do solicit support from the development partners, financial and technical support, but largely these supports are uncoordinated. So it's something that we plan to make sure that we strengthen that and set up this particular system. In putting this document together, we made reference or review other documents nationally and internationally. We look at our own national health policy document, the objectives and the goals in there to guide us. We also made reference to the universal health coverage content of We also made reference to other international documents to guide us develop this particular strategy. So the goal of this strategy, as we have put together, is to institutionalize and integrate health information systems that ensures availability of quality health data for decision-making at all levels of the system. And we came up with 3 main objectives. The 4th one is just how to ensure that we implement this strategy. But the 3 main objectives, the first one is to make sure that we improve the environment for this health information management to work, and also improve data sharing among the agencies of the Ministry of Health so that we can have timely access to the data for analysis for our managers to make informed decisions. And we also want to improve the capacity at all levels of the system so that they'll be able to collect the data, analyze, validate it, and transmit to the central point where our managers can make use of it to take decisions. And also to make sure that this strategy that we have put together will not be shelved, but we will follow the content, receive the approval from our bosses to get it implemented, so that we all benefit from what we seek to expect. So why are we doing this? We are all aware that we have governance and coordination challenges in our current health information systems. There are lack of standards for health information practices. We have so many systems in our agencies. Some softwares are even duplicated. They don't talk to each other. So that is one reason why we put together this strategy to address that. The other need for this strategy is that we don't have all the private health facilities reporting to the DIMS that we have currently, the DIMS2 platform. So we believe that if you're able to set up a centralized database where all the facilities can report to, then we have a comprehensive data to work, analyze, and use it for decision making. And then we also recognize that even though there's an increased demand for management, information, and dissemination, the resources to get this thing done is also unmatched. So if you look at the increased demand and the resources available, they don't match. So we plan to also seek resources, both financial and technical, from all stakeholders to be able to set up this particular system that we are talking about. So this is just to show you how health services delivery or the healthcare system in Ghana is organized. And if you look at it, it's not different from what we have in Africa and other countries. It has a hierarchy structure where the ministry sits at the top and provide policy and strategic direction for the agencies and the other stakeholders. We have the tertiary facilities, mainly the teaching hospitals, Kolobu Teaching Hospital, Komfanoche, Tamale, Ho teaching hospitals, and they provide specialized services and also serve as referral facilities to receive referrals from the lower level of the system. The regional facilities are also there, and this comprises mainly the Ghana Health Service facilities, as well as the psychiatric facilities or hospitals that we have in the country. And they also provide specialized services, clinical and diagnostic services to the population. We have the district hospitals that support the sub-district hospitals in terms of providing care and also receiving referrals from them. And these facilities mainly are the Ghana Health Service facilities or the public facilities. We also have private as well. Then the sub-district level, where we have basic curative services being provided to the population, as well as maternity care. And then the community level, where the community nurses provide actual services for the people in the community. Aside these service delivery agencies, you also have the regulators. HEFRA is here. We have the health purchasers, the National Health Insurance Authority. And yes, so these are the service delivery agencies, the regulators and purchasers of our healthcare system. If you look at our healthcare system, you receive data from different sources. So in Ghana, these are the main sources of health data that we have. The routine administrative health data that we normally generate from the facility level and store in the DIMS2 platform. We also have the human resource management information to provide non-service data for analysis. And then we also have the logistics management information system that takes care of our logistics. The National Health Insurance Information System, that gives us information on the membership of the population, the claims data. And then we also have the civil registration and vital statistics. So the births and deaths data are also generated and stored in this particular system. The population and housing census gives us data on the population, the demographic data on the population. And we just had one for the 2021. And then the population-based service. We do also conduct demographic health surveys, the malaria indicator survey, maternal health surveys, and others. And as well as facility surveys. At times, the facilities also conduct their own surveys to help them correct other things in the operations. So if you look at the system as we have in Ghana, the public-private quasi-government facilities, as I mentioned earlier, they generate administrative data, and these data are stored in systems at that facility level. So we have the e-tracker. We also have the electronic medical record system. We have the teaching hospital. So data from the teaching hospital goes into this system. And as you can see from this diagram, they all go into a central point at the top, where we store them in the e-tracker, or we store them in the district health management information system, or the teaching hospitals platform, as we refer to it as TIMS. So data generated at the district level, at the facility level, are transmitted into these data systems up there. If you take the Ghana Health Service facility, for instance, they go through a structure from the sub-district level to the municipal level through to the regional levels. And I believe that all these steps do validation before the data gets to the central point where all of us can rely on to use and make decisions. So that is the current architecture for data transmission from our facilities to the central point. So I'll take you through the analysis of this current status of Ghana's health information system. So the strength, we've done a lot. So as you can all see, data system exists in the country. and it allows agency-specific data. If you look at all the agencies, they have data system to capture data for their own use. We also have governance structures as to how the data is collected, the data is used, analyzed, and shared with other stakeholders. There's also availability of software in almost all the agencies. Some agencies also have a well-defined structure to make sure that the data that they have, security-wise and everything, is also protected. However, we have weaknesses in our system. The first one being integration and alignment. We talk about coordination. How do all these systems talk to each other? We also have poor data dissemination. Even though we have huge data storage, how this data is analyzed and disseminated for policy making is not up there, it's not optimal. We also have low confidence in the generation of the data. And this goes to talk about the quality of the data that we generate for use. The coordination structures for information, monitoring, evaluation functions. We have structures that help us to coordinate the collection, analysis, and all those things. And we believe that it's not functioning as expected. Inconsistent data structures across agencies. This one relates to facility codes. So if you go to some of the facilities, the agencies, the system recognizes different codes for the facilities that we have. And we believe that going forward, we should have one code for all facilities to support analysis. And we also agree that large proportion of the data that we generate are analyzed manually. And I think it's time that we move away or reduce the manual processing of the data. And then the weak structures for collecting non-service data, human resource data, and other data, we need to also find ways to make sure that we strengthen that and get all this data into a centralized point for use. Opportunities exist for us to do this. The first one being that standards exist for data security. Thankfully, we have the National Protection Data Agency, Data Protection Agency. We also have the National Information Technology Agency. And these institutions help us in terms of data protection and others. Then local vendors are also available to give us solutions to address some of the challenges that we have talked about. There's also goodwill from our development partners and stakeholders in general concerning this particular subject that we are discussing this morning. And we believe that we can leverage that to get this document implemented. Experts also, we have a lot in our systems. If you look at the DIMS2, it tells you that we have experts who are able to generate the data and transmit to us, but we need to strengthen their capacity as well. We can also rely on experts from the academia to support us do this. And then we've also recognized the importance of non-service data. So going forward, we will also make sure that non-service data are also collected and also stored, used for decision making. But we need to be careful in doing all these things because some of these vendors store the data outside the shores of Ghana, which have, if you like, security implications. So whilst we strive to get this document implemented, we also take cognizance of the fact that some of the data that are stored are not stored outside the shores of Ghana. Then inadequate budgetary allocation may also affect operations of the various committees. We have structures that will make sure that this document is implemented, but we will need budgetary allocation to make sure that their committees and other functions that they may undertake are done smoothly. We also want to be careful to rely on our DPs for support too much because they also have interest. So we look forward to a win-win situation to get this done. Then we can also rely on different standards, our international standards, to guide us in the implementation of this document. And then at the agenda of development partners, okay, I think this one is the same as the interest that I talk about. So how are we going to do this? The 4 objectives that we just mentioned or talk about. The first one is to improve the environment for this particular health information system to work. And the team that work on this document proposed that first, we need to have a policy and legislative environment to guide the operationalization of this particular document. We also need to strengthen the governance information system. facilitate access to relevant data sharing and dissemination. And there was a consensus that we upgrade DAMES2, which is our largest database, health database in the system, to maybe serve as the central repository for all data that we seek to collect from the sector, to go into it, and then we will use it. Then we need to also expand available financial resources. As I said, when we get to the budget session, you will see how much it will cost the MOH or the sector to implement this. So it means that we need to look elsewhere to get extra money to support this particular activity. And then the second objective is to improve data sharing among our agencies, the dissemination and use by our managers of the sector. And how we want to do this is that we want to develop a system-wide method that will allow us to share health information. We also want to build capacity for the development and maintenance of health information architecture. So it's not just the data, but the system that support the collection, storage of the data. We also look at that. And then harmonize and standardize the capturing tools. So the data collection tools, which are used mainly from the lower level where the data, or the facility level where the data is generated, we also want to make sure that these data collection tools are standardized. And then integrate the existing fragmented data information system. As I mentioned earlier, almost all the agencies have a system to collect data. But how do we integrate this? Let them talk to each other so that we have a central point to have all this information stored. Then improve the coordination for data sharing. Some of the agencies, it came up yesterday during the plenary session that information sharing is not up there. There's overprotection of some of the data that our agencies generate. Then we also want to create more fora. We don't want to generate this data and then let it be in our databases, but also make room for the academia students to have access to the data, use it, and make presentation to our managers so that they can also use the findings or the evidence from that to guide their decision making. The third objective, which looks at the capacity for managing the information that we collect. The strategies that we put forward were that, one, we want to promote the use of locally developed information system. So a local content is also being considered here. We have the expertise to develop the system for us to use. So we look internally to get solutions for that. And provide logistic and technical assistance at all levels. So we need to strengthen the systems at all levels to be able to collect data for use. And explore technical assistance from our development partners. We cannot do it all, so we also want to rely on their technical and financial support. And then digitize all the data collection tools. So the data collection tools that are being used currently, we will make sure that we digitize all of them to facilitate timely data collection and access. The fourth objective is to make sure that this document that we have put together, we can implement it and gain the benefits that we want to see. So we will track the implementation of this strategy. We will conduct independent assessment. There will be a midterm and end-term assessment of this particular plan. This strategy will run between 2022 to 2025. So mid-year, we will do a mid-year independent assessment to see how far we are doing with the content or the implementation. And also expand the coverage of private sector services to also transmit their data into the national database. So the proposed architecture for the health information system, as we have put together here, is that if you look at the bottom, you see the service delivery agencies. So they will generate data which will be aggregated at the next level. The teaching hospital, that will be the DAMES2 platform. The teaching hospital will also have an instance or a page on that platform to also transmit their data. All the other facilities also have their page to transmit the data. And then all this will go into a service delivery dashboard, database, if you like. So this is for the service delivery agencies. On the left, you see the teaching hospital, you see the training institutions. We also need data from the health training institutions, so they also generate data. On the right-hand side, you see the regulatory agencies. We also need data from HEFRA, the accreditation and licensing information. We need all those data. How many facilities that we have in this country, and at what level, and what the types of facilities. We need all those information, so they will also generate the data. And then the National Health Insurance Authority also generate the data. So data from all these institutions will then be aggregated at the national level into a centralized database. That will be managed by the Center for Health Information Systems, so that at the ministry level, the managers will have access to the information. If the Honorable Minister is going to the press, we can have timely access to information to put together a press briefing for him. So that is the proposed architecture that the committee put forward into this document. Then the management and coordination arrangement. How do we make sure that we get this particular document implemented? So we will seek ministerial directive from our Honorable Minister. We will also seek financial arrangement through the existing financial system. So the budgetary allocation of the ministry, if possible, we will also make a budgetary line for this particular document. And then the governance and coordination. The Ministry of Health will take charge in terms of leading this implementation. We will have other structures like the Interagency Leadership Committee providing approvals for some of the decisions that will be taken. Then the Information Monitoring Evaluation Technical Working Group will also be used to provide technical assistance. And then the Ministry of Health agencies, including GACI, and all the other agencies will support in the implementation of this document, because the document is ours. And as I mentioned, the Center for Health Information Management will manage the data for us. For the monitoring and evaluation, we will continue to track the performance of the implementation of this particular strategy. And we believe that it will also help us to learn from that. So we promote learning as we track performance. We share and give feedback to those who are implementing it. And then this will be done quantitatively and qualitatively. So we will not just sit here and wait for quantitative data to come. We will also go and do interview to understand some of the challenges and how best we address them to get this document implemented. And at the end of it, or as I mentioned, there will be 2 evaluations, the midterm evaluation and end-term evaluation of this whole strategy. The concept of implementation is said that, as it's not different from what I showed earlier, the ministry will take charge, will do the coordination work. The lead implementers will submit proposals. There will be different implementers in this particular strategy. So they will submit proposals as to what content or aspect that they want to implement, and then we will look at that. The Information Monitoring Evaluation Technical Working Group will review some of these things and provide guidance. The Interagency Leadership Committee will provide the approvals for some of these proposals to be accepted and then implemented. So the arrangement is said that the M&E unit of the ministry will lead. The Information Monitoring Evaluation Technical Group will also continue to provide technical support. The Interagency Committee will also give approval for some of the decisions, and the lead implementers of the strategic plan as well. The budget as we put together for each of the objectives. If you see the first one, where we want to improve the environment within which this strategy will work, is roughly around 2.4 million Ghana cedis. The second objective, which is to improve sharing of data among the agencies, is around 23 million Ghana cedis. And then the capacity for managing the data that we collect at all levels is a little over 1 million Ghana cedis. So if you put all together, we are looking forward to an amount of 27.3 million Ghana cedis. So clearly, we will need support from our development partners to be able to do this. In putting up or putting together this particular strategy, we receive support from our Honorable Minister, the Deputy Ministers, the Chief Director, Directors and Unit Heads of the Ministry, the Technical Working Group that did this job, the US USAID Accelerator, they also supported us financially. And all the stakeholders, we had a stakeholder engagement of this document somewhere last year, last quarter. So we thank you all for the support that you provided for the team to come out with this particular document. Thank you.
Thank you very much, Dr. Nsiah-Boateng. Dr. Vanuatu, what we want to do is that this is our own document that we are finalizing and putting a nail in the coffin. So we would open the floor for some comments and feedback on it. But before you do so, just to acknowledge the presence of the Honorable Minister. He's been with us through our presentations. We also want to recognize Dr. Divine Bangu Bala. Wow, okay. It's how it's spelled for me here. Divine is okay. Thank you for saving me. Registrar for the MDC, Dr. Hafiz Tahir, Director, External Health Coordination, MOH. Mr. Hamidu Adakrugu, Director, General Administration. And Dr. Daniel Asari, former CEO of Kolebu. So we want to take some feedback and some comments. We'll start with our online participants, and then we will come in person. Thank you. Dr. Vanuatu.
Yes, thank you very much. And let me add my voice to welcome all participants who have joined us from the institutions, the academic institutions, and also from very far away. Some of them have had challenges to join, those of they continue to join. And so we welcome all of you. But we have had two presentations and comments that have come in. One from Dr. Innocent, and says that thank you for the excellent presentation. That's Dr. Benson. And what would be your comment regarding community health information system? So as we move forward, I believe that this will be one of the things that we will be looking at. And how does it logically fit the architecture you have described? From the Ghana system that we just heard, we heard about the community side of it. So I believe that that will be taken care of probably during the discussion. And then with that, we want to says that Dr. Benson, your presentation captured all the issues that need to be captured. But somebody would want to know, it says great initiative. I'm really excited to hear that data will be made available for academic collaboration. My hope is that in the data collection process, we consider the structure of data that is academic research, which means that they should be involved as well with the collection of the data. I hope you have time for you to make your contributions during the discussions. Then we have from Dr. Benson, he says that the MOH HMIS capture data from the military, given their concerns security. Then, Dr. Sifas Abota, very impressive presentation. I hope that this new data ecosystem will welcome multi-sectoral collaboration, especially in the area of the One Health approach. So it's also bringing in another aspect of it. Then, it says that from Dr. Francis Acosta Group, yes, I would like to know if the MOE is set up a digital health unit that will coordinate efforts in digital health in Ghana. Finally, these are some of the comments that we have from our participants online. So I believe they will have opportunity to answer them and discuss them further. Thank you.
Thank you very much. Yeah, thank you very much, Dr. Vanuatu. I thought there were two clear questions that came out. The rest were comments that were made. I don't know if you want to take them. The first one was, do we collect data from the military? And then the second one was, will there be a digital health unit set up at the Ministry of Health to lead this agenda? Those are the two questions.
I'm very sorry to interrupt. I just want to I have to go for another function with the launching of the Lancet report on cancers. So I have to leave, but I just want to say one or two things. The presenter, Dr. Nsia, the one you mentioned, Kaki, please try and add on the security agencies' facilities because they get lost. That is why somebody is asking. You never mentioned them, and they wouldn't easily accept it as part of Kaki. So let's single them out. So now have about how many providers? Ghana Health Service, CHAG, Kaki, private sector, the security agencies' facilities, the police, the military. Now here the prisons, also establishing hospitals, and they should also be singled out. But the Director General tells me that they all send data to us. The military hospital shares data with the regional directorate, and therefore we have their data. But we'll enforce them to join our crusade. The other question, I don't see how much difference we have between the Health Information Management Center and then the digital unit somebody is talking about to be set up. It's just a matter of semantics. They all can coincide. But we've taken note of that, and we'll try to highlight this thing again in the revised strategy, said that all these suggestions can be captured into it before we launch it. Thank you. But that means that I'll use the opportunity to plead that I will exit and come back to join you in the afternoon. Thank you.
Yes, please.
Thank you. Then the mic is closed, so let me ask my question. Dr. Nsia, I think data is money. I didn't see that. Are we just going to give data free? And I think all the money we are spending, we must also have a way of generating resources from the data we collect. No, it's so expensive. They even steal it.
We want everything for free.
Thank you very much.
Mine is more of a comment. I think this is a very good, excellent start, but my comments are more how we can improve. My first point is it's important that the system we develop are more to address also problems of the future, not just the past. In the past, the whole purpose of health information system was focused on managers, helping managers make decisions. In the future, it's not only managers who are interested in information. The public is interested in information. Our health information system has also helped in accountability. And yet this system is still focusing on the past. There is nothing in this system about financial information system. You can't talk about health information system in the future without financial system. That's why we are struggling. How much have you spent on COVID? We are struggling because it's not part of the information we collect routinely. The focus of this presentation is all on service data. So that is really my main concern. We're still looking at the past, not into the future. My second point is that this is about universal health coverage. We've defined universal health coverage, including preventive, promotive. But this system is still sickness care. We said our system is based on tertiary. We don't have tertiary preventive services. We don't have tertiary promotive services. So it's still very much sickness care data and not universal health coverage data. There's no data on emergencies. So I will advise that that component is looked at. This is still very traditional 10, 20 years ago health information system. But it's an excellent beginning. Thank you.
Thank you very much. Please, you can use the microphone at the front. Yes, it's on. Hello.
Okay, thank you very much. One of the points I'm going to raise might be related to the last point that was already raised. The process of finalization of this draft. Can you highlight a few more points on that so that there will be a chance to contribute on the good draft that is there? The other point I want to raise is that there is a need for a robust monitoring and evaluation plan for either the UHC roadmap or mainly the medium-term strategic plan that has recently been finalized. Where are we with that monitoring and evaluation plan? I don't see it being mentioned here in the strategy. At the end of the day, the strategy is there to generate resources to monitor the medium-term plan and the health sector medium-term plan. The other point is key issues like periodic and predictable surveys, population-based surveys as well as facility-based surveys, financial information, health workforce accounts, national health accounts, and the likes that are, to some extent, needs to be strengthened, may need to be mentioned in the strategy, as well as birth and death registration. So specific issues that may need to be mentioned in the strategy. If they are not mentioned, it's good they are mentioned. And if the process of finalization should also be informed to us so that we'll come up with specific inputs on the very good draft that's already there. Thank you.
Thank you very much.
Good morning. So this question is kind of attached to yesterday's question. Given the drop in support from the government of Ghana and the president's Ghana Beyond Aid strategy, along with donor partners looking at exit strategies, where does the health information system strategy come in at on the priority level with the monies that remain?
Okay, so yes, please.
Thank you very much, and thanks for the presentation. I think it's a very good start. One of the areas that we need to look at is the births and deaths registration. And I'm wondering how you are going to, because if you are going to talk about strengthening data, then that's a vital area that we really need to strengthen. How you are going to link that? Thank you.
Thank you very much.
I'd like to add to what the DG has said about monetizing the records. We don't have in this system think tanks that deal with health issues. We have Imani, we have so many of them dealing with social issues. But we don't have any think tank. But the think tanks that take the information, they buy the information, and they sell information to institutions, to pharmaceutical companies, to equipment manufacturers to make money. And that is completely lacking in it. Because if you don't have those institutions in place, you can't monetize you can't leverage the information you get, because it must go to the pharmaceutical companies, it must go to drug manufacturers, it must go to equipment manufacturers, it must go to all of those things that are non-service providers who will use the information. That's number one. Number two, for me, Dr. Anafi Ba is here. The place of the Minister of Health in cabinet, I always have said it and I'm saying it again, in the colonial days, when the Governor General is not around, when the Deputy General is not around, the next person who acted for him was the Director of Medical Services, or was the Director of Service. So our first Dean of the Medical School acted in 1958-59 on behalf, because it was assumed that everything ends in health. Communication ends in health. Energy ends in health. Transport ends in health. Agriculture ends in health. So if we don't now, the Minister of Health has no place in the scheme of affairs. It's the Chief Justice, it's the lawyers, it's the security services. But if you don't argue, if you don't raise the level of the Minister of Health, that everything ends in health. Road networks must end in the health of the people. Energy must end, fishes must end in health. Then we'll have this problem. That is why I am just want to make this place that we need to bring the level of the Minister of Health in cabinet. That everything else should end in the health of the people. When we think of that, we have health impact assessment for everything instead of environmental impact assessment. Then we can have that, and that's all I want to contribute. Thank you very much.
Thank you very much.
I just want to direct this question to you, just to enrich some of the things. You made a very good start. Where does Ghana card sit in this new model that you have just? This is where we are beginning as hospital facilities to generate one number from birth to death. That links so that your hospital number becomes your Ghana card number. So straight away, birth and death registry can pick it up. So all the community members, families, every Ghanaian will now be part of the digital platform. But if you set up a separate system outside the Ghana and what you call card system, then you need to find a way of integrating. Let's begin with integrative. Let's try to merge the two. Let's have a whole digital center where health has a component so that we can share data. Because having hospital number and somebody dies, and then later on you are going to extract the number to go and find who died. When the person has a card, and that card becomes a registrable thing for every transaction, financial transaction, everything. That's where we'll be moving forward in the future. So I want to thank you for that.
Thank you very much. I think we'll take some responses.
Good morning again. Who just made a point about the importance of the health ministry? Yes, my brother, I'm so happy about this. Very happy because, as you said, everything ends at health. Let me give you something that happened in Parliament. When the Speaker, Abeng Bagben, for me, I'm the MP for the Boya Mankaro constituency. When he struggled in Dubai for several weeks and came back, he made a categorical statement, and I felt that we should take it upon. He said the most important ministry in the world is the health ministry. And I nearly ran away from Parliament. I said, when did you discover this? You see, it appears in Parliament, everybody wants to be in the finance committee. Me who worked in finance for 35 years, when they were selecting me, they took me to a Greek. Then, and gender. By any time they want to contribute, Kofi Kwache, he was the deputy minister there. We used to meet at the finance level to make some analysis. I'm from customs. I'm a revenue officer. Then he came and told me that he wanted to make me a friend of the finance committee. This comment that you made when the minister was not there, it pained me a lot. Because I would tell him that, look, if you are sleeping at cabinet level, let's tell the president that everything stops at the ministry. And we'll take it up with all of you, the stakeholders, talking about this. You help us to build a very strong case And at cabinet level, we will always be on top. Otherwise, like my brother, I don't know the name, you made a very, very strong decision. Now we are preaching Ghana Beyond It. Our partners and stakeholders are reducing their funding. Where are we? And we are not stepping up the importance of the ministry. We are beginning to collapse, so down, 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 down. So please, those of you who are professionals in this ministry, I'm just a politician. The ministry is the most important ministry in the world. And I'll end by saying that the memory of the dead is a warning to a living.
Thank you. Thank you very much. We want to take some online comments after we've had. Yes.
Is not deep enough, and that is what's creating the gaps. Next month, we'll be launching an application that links with birth and deaths, that as soon as you are born, you are given a Ghana card. And this is something that has already been worked out. The document needs to do further analysis into the situation so that, because I don't know how you arrive at your gap, your budget, if you haven't done such a detailed situation. So I feel that as part of your rollout is to do further situation analysis. So exactly what is infrastructure available, what are the gaps, so that we can really implement this properly. Thank you.
Thank you very much. We want to take some feedback where you can give feedback, and then we'll go online. Thank you.
So thank you very much. Let me start by saying that we thank you for all the suggestions and recommendations. The committee will go back and look at them and incorporate them into the document. So I will say that for now, and then try to respond to some of the issues that I think at this level I'll be able to do so. The rest, when we go back as a committee, we'll look at it together and address them. The process of finalizing this document, as I mentioned, we have already done dissemination workshop with the technical people at the agency level. So this presentation was also meant to get further feedback from participants and stakeholders, as you have already given us. So from here, the committee will go back and look at the document and incorporate some of these very good recommendations. We have also developed the MNE plan. It's also there, just that we did not bring the full document here, but the team has developed an MNE plan to track implementation of this particular strategy. The births and deaths registration is also taken care of in our main document. We are aware that some of the institutions, the health facilities, have offices for these births and deaths over there to capture data. So it will be easier for us to also link up and get the data into what we want to do, the national database. Then priority level, that is a very big question. But at this level, I will leave it. We will discuss it. We will discuss, yes. At my level, I will leave it. Then how do we monetize? I think it was a very good suggestion from DG that data generation, collection is very expensive. So we need to also put systems in place that will also bring some amount of money to the system. DG, what I can say is that this is the strategy. A policy document will also be developed to guide how these things will be implemented. Okay, I think for now, the rest are suggestions that we have taken them on board. Thank you.
Just to add a bit, I think the essence of this draft actually was exactly this, to hear from stakeholders the various input that should go into finalization. I think even listening carefully might even have to broaden the stakeholders to bring on board a few more stakeholders. The aim was to do it in a cascaded fashion. I also want to touch on the digital health. I think digital health is broader than this health information system. I think it's more of a configuration issue we may have to discuss and look at the architecture as we have it now. And then I think the last point was on I wanted to make a point. We've noticed that a lot of data work is happening also under the auspice of the Vice President. So as part of what the Director General said, we are going to have a broader engagement around there to really see all the data efforts going on under that office and ensure that whatever we are doing in sync with broader government direction. So these points are well noted, and thank you once again.
Thank you very much, Dr. Dami. Dr. Van Otu.
Yes. Exactly what should happen is happening, and that is to show that a lot of people are interested in data and how we can use all that we collect in the various facilities for decision making and to improve the health of the people. So many of the comments have been answered through the discussions. The last one which I wanted to touch on is what Dr. Dami just mentioned about the difference between the e-health and the digital health. So I believe that most of it has been done. But people are looking at include lots of pharmacy information, include this, include that. But I think that the document has service and non-service. And therefore, as the team sits down to review based on all the comments and others that might come in, we'll be able to include other things that have not been included. And also, looking at the presentation from Dr. Benson, there might be other areas that would need to be looked at. And people are still interested in the community data, the data from the community, and I believe that that would also be looked at as we review the documents, I don't know, maybe for final review before it becomes something to work on. Somebody is also concerned that we are in the third year and the training will take place late, and how will that fit? Will there be a good time to have the training? Shouldn't it have happened earlier? I believe all this will be taken into account as we look at the rollout of the document. So these are some of the questions that we have online. But let me take this opportunity to also recognize some of our seniors, Dr. Agana, Dr. Sos, Dr. Bannerman, and others who have worked tirelessly to make the service what it is now. On our agenda, this session was not really part of it, but I think it was necessary. We were supposed to have gone for snack break by now, but not before we have another one on the reflections on the e-health system, the lightweight. If that is ready, or Kwame, if that is ready, we can have that. Otherwise, people have been sitting for a long time. And after the snack, we'll be going into the parallel sessions, which means that we'll not be coming back here. We'll show you how to select which one you want to be part of. But the parallel sessions will discuss what we want to discuss, the health data governance for UHC. We'll have capacity of the health system to generate, manage, and use data, and the health data infrastructure, architecture, and interoperability. All these would help to address some of the issues that have been raised after the presentation. So we have this lightweight, very short presentation, and then we'll let people know how they can select the panel sessions that they want to join, and then we'll break for snack. Kwame.
Yeah, thank you. Sorry we are not able to take additional comments now, but like we said, the panel discussions also provide a forum where we can articulate our comments and our views. So we'll take the next round of videos on the reflections. Thank you. Probably we can have the lights off so that we can see the video as well. Thank you.
Electronic medical record systems, which is being rolled out under the light health patient system. Most of our essential services have been become paperless in the hospital. In times past, we have had challenges in terms of retrieving patient folders, for instance. There have been cases where some folders were missing. Also, data collection and data analysis was a big challenge to assemble all the folders and actually retrieve, diagnosis, and all the data capture was a big problem. All these things have now become a thing of the past. Now you just go coming here once you have entered, you just go before the doctor in the consulting room and your extension number, all the data on you is actually retrieved from the system. There is also linkage between the various specialty areas and other service areas such as laboratory and radiology. Also, data analysis or data collation has also become much easier because all these are now in the electronic system, and with the press of a button, you are able to retrieve specific data depending on the entry that is made on the patient. Now the billing system is much easier because it's electronic, and there's very little human involvement to interfere or to manipulate the billing system. And therefore, a lot of our services, or much more, are being captured for billing and therefore for payment of revenue.
The problem had been if a patient, for example, is sent to me from surgery, this patient will have to come with his folder. Sometimes I will need some information about this patient that is related to, let's say, medicine. It means I need to get that patient's folder from medicine. So one patient is having like 2 folders with different patient IDs. But with the limbs, the patient comes in with just one ID. I have all his information from my surgical colleagues. I can also have his information from medicine, from the laboratory services, from radiology. They'll all be loaded onto the system. Before this system, I'll have to chase different folders in order to get all this information. So this has made our work very easy. It's like a one-point shop where you have everything about the patient.
The e-health has gone a long way to improve patient safety with respect to their medication therapy and management. The e-health has consolidated all clinics in the hospital such that when a medication is served to a particular patient in a certain clinic, it reflects in all interfaces in the pharmacies such that you can see all prescriptions dispensed to a particular patient, thereby reducing the number of times prescriptions are dispensed to a particular patient. That is, if it's the same prescription from different directories.
The challenges are to do with the human resource, as we have indicated. We have had to train and retrain staff, but not every hospital is on the system. So if you have transferred staff or staff who are being recruited freshly into the system, you have to train them. In terms of infrastructure, practitioners experience some kind of slowness in the processing of patients in the consulting rooms, in the theaters, and on the wards. And we are trying to improve to have a better and bigger capacity to make to improve the speed. And then also, in terms of the power system, more often than not, when we encounter power outages, even though we have our standby generator to come on board, it causes some kind of transient interruption on the system, where in some cases, some computers will have to be restarted all over, and in some cases, there have been lots of information. We put in place a monitoring team, for instance, that is constantly monitoring the system and also reporting to us on a monthly basis. This committee has clearly an arduous task because they go through the system and they do some kind of electronic auditing to give us reports on who have been on the system to make sure that we get a report that advises management on the kind of investment, the training program that we need. We have actually taken some of our IT people through cybersecurity training, for instance, for them to be able to also assist with the monitoring of the system. And we also need to make sure that going forward, we have more collaboration to improve the kind of IT hardware that we have. We have had to buy a lot of computers, but we still need a lot more to make sure that we are able to leverage for very easy application at various sites of the hospital.
The Electronic Health Records Project is an integrated patient medical records in the Cape Coast Teaching Hospital, which is supported by the Ministry of Health nationally and coordinated by the Lightwave Healthcare Solutions locally. At CCTH, it is coordinated by the management of the hospital. The Electronic Health Records Project key objectives are to enhance health data information management systems, improve data reporting systems in the health sector, improve facility-to-facility referral system, and also to improve patient management system and help track diseases in real time and trigger prompt response to key stakeholders. The applications have helped us a lot in improving on our supervision and monitoring of the healthcare team within the hospital. We're able to, with the click of a button, identify a consulting room and see which consultant worked, how many cases he saw. It has also helped us to monitor our beds and has eliminated completely the no-bed syndrome that we used to have in the past. It offers us the opportunity to create virtual beds and admit the patient even as we look around for physical beds for their admission. It has helped us eliminate completely missing folders. Our inventory management has also improved. We don't dispense from zero stocks. So you're able to monitor, even in the pharmacy, how many tablets you have served of a particular medication